Okay, guys, I hope that this is working okay. We are going to do something just a little bit different today because I got an email this morning that said they are experiencing global issues with Zoom. And being how our first class is scheduled to meet over Zoom, I thought as a precautionary measure, I would just record our first lecture in parts and post it on YouTube, and then I'll put the links to the YouTube videos on either our syllabus or in Blackboard where you guys can access them. In case you want to review this, we'll teach it different. I never say the same thing twice because I am not that smart. So you'll have it as a reference, or if it all goes bad tomorrow, you'll have it as your primary teaching tool. I'm hoping that Zoom is working tomorrow so that we can do introductions and I can meet you all over the computer and all of those things. But for now, I think it might just be okay to kind of dive into the actual lesson part of our first day. And so, again, the voice behind this phone is Amanda, and welcome to Respiratory Care 217. We are teaching and learning pulmonary assessment. So I have to break the ice and start out with a joke because I'm kind of a jokester. Well, you guys will figure that out as we go. And this is, you'll hear this down the hall occasionally when your patients get in trouble or something that the nurse doesn't like to see happens in the room. This is typically what happens. And so I've seen this a lot of times in my life. I've experienced this a lot of times in my life, and I think it's kind of a good representation of how important you are to the care team, and also how heavily people rely on RT, especially now, and also for your knowledge. So I'm going to do my best to teach you how to do a thorough pulmonary assessment so that when this happens, you know what you're doing when you run into the room. Course description, theory and application of the basic pulmonary assessment, including inspection, so what you see, palpation, what you feel, percussion, what you hear, and auscultation, what you hear. Percussion is, we'll talk about that on a different session, but it's using percussion to determine what's underneath there. So our primary objective is to use our stethoscopes in our hands and our eyes and try to figure out what's happening underneath that rib cage and why we're actually needed in this patient's care. This YouTube video right here, I'm not sure if you can see my mouse, this YouTube video is amazing, and I'm actually just going to post this as part of I'll just post it separately for you guys to be able to watch it. It's a nursing video on thoracic landmarks and where to auscultate, and she does such a good job. I don't feel like there is any need for me to reinvent that wheel. So I will go ahead and post this for you guys on our syllabus with this YouTube video that I'm making, and you guys can view this, and it's very, very good. And so that's something I want you guys to probably do, for sure do it before next week. Dream big, set goals, and take action. So little motivational speaking here. I do want you guys to dream big and set goals and take action. The respiratory care program it's not easy. I went through it a few years ago, 19-ish years ago, 20 years ago. I think I started in 99. I don't know. I'm not a math major. I should be able to do that math, right? So 21 years ago, I was in the RT program at Boise State, and it is difficult. It is challenging, but it is very rewarding. So dream big, learn everything you can. You'll have amazing faculty and amazing resources. Even though it's 2020, everyone is going to do their best to get you guys the best respiratory care education that you can. We are going to do YouTube videos from home, and we're going to do Panopto, and we're going to do in-lab things when we can, and we're going to do everything we can, despite it being the year 2020, to get you guys a good education. So set goals and take action and work hard. Okay, Egan's chapter 16. So this is off the 11th edition. And so if you ended up getting the 12th edition, because Ryan told me a couple days that that's out, and I apologize, I don't have access to it, but essentially it's the pulmonary assessment or chest assessment chapter in edition 11. So if you guys have edition 12, please let me know, and I can get better references for what I wanted you guys to learn on this. But pretty much I'm kind of just going to summarize it for you, because I don't want you to spend a ton of time worrying about that. Your pulmonary assessment, or your assessment of every patient, doesn't actually begin when you walk in the patient's room. And sometimes we think that it does, but your assessment of your patient actually begins when you either get report on that patient from another therapist, or you get an order for a new start. And so some things that you have to think about are your assessment really begins when that patient is handed over to you, either by report from another RT, and we'll learn a lot about that in the next few minutes, or that you're doing a interview process with them, or a chart review on them, and some ways to get good answers and a good assessment of kind of how things are going for your patient are just the importance of the interview process. And you have to establish a rapport with your patient. You have to have a sense of undivided interest in them. If you're distracted, or it's hard not to be nervous sometimes going into the room for the first time, but you want your patient to know that they are your priority while you're in there. You want to always establish your professional role, so always introduce yourself as you are. My name's Amanda, I'm from respiratory therapy, and so that they know where you're from and what you're doing in there, and always, let them know I'm here to check on your breathing, and if you have therapies, always tell the patient, always establish your role and tell the patient what you're doing in there right at the beginning. It gives them a little bit of confidence in you. Show respect for the patient's beliefs, attitudes, and rights. So sometimes the patients will be happy to see you, and other times they most definitely won't. But you have to show respect for however they're doing. You want to obtain the pertinent information from them and help monitor changes in the patient condition and response to therapy. So that's just kind of a little bit of a synopsis of some of this. So patient interview and Sbar, and this YouTube section is actually going to be dedicated pretty much mostly to Sbar, and we'll get into that in the next couple of slides. Interview skills are key. So like we said before, you want to give the patient your undivided attention, so you want to make eye contact with them. It's really important to make eye contact with your patient, because if you don't, they don't. Some of them, this will be a challenging thing. Because some of them read lips, and if you have a patient that's hard of hearing, and now we're all going to be wearing masks for every ounce of patient care, so that'll be difficult. So because they are not going to be able to read your lips, it's really important that you make eye contact with them. Clearly introduce yourself and address your patient by their name. And so you want to, like we said before, you want to identify yourself and your professional role, what you're doing. You want to introduce yourself that way, and then address the patient by their name. And that's important, and you'll learn all this in your standard protocol, but that's really important. It's a checks and balances system too, to make sure that you're in the right patient's room and treating the right patient. Ask open-ended questions, and we all know kind of how and why that's important. A few examples. Listen to your patient's response and construct new questions as you go. So, do you smoke? No. Did you ever smoke? Yes, but for about 30 years. So if you are trying to obtain a history from your patient and you ask them if they smoked, they say no, and you don't follow up with that, did you ever smoke? you're going to only have part of the information, because if they say yes, but only for about 30 years, then now all of a sudden you know that maybe their wheezing isn't an acute thing, or it's an acute on chronic thing. When did you quit? Yesterday when I was admitted. So is this patient a smoker? Yes, this patient's a smoker. Would you have known had you stopped at the beginning? Probably not. You would have just said, nope, they're not a smoker. They're not a smoker. And that's just an example. So the Sbar that we are going to use, we're going to talk about this a fair amount in this class, because I feel like it's really important for communication with other healthcare providers, but also for organization for you when you're getting ready to see your patient. Because like I had said earlier, I don't think the pulmonary assessment starts when you walk in the patient's room. I think the pulmonary assessment starts when you get report from that on that patient, or you're looking in their chart and doing a chart review prior to that patient being a new start for you, a new start therapy. So S stands for situation. So under the situation part of this is really easy stuff that you're going to gather from your patient's chart and their or their interview, whichever you prefer. So name, age, gender, room number, admission, diagnosis, and code status. And this slide will come up every week from now till week 7. And actually week 6, because week 7 is just a check off. And I want you guys to kind of just think through why this is important. So this is how you will give report on your patient. This is how you will receive report on your patient. And a lot of times it's really nice to write down your patient's information in this format when you're doing a new start or taking report, because then you know a lot about the patient in a very organized manner. So that's why we're doing it this way, is so that it helps you to get organized from the very beginning. Before you even see the patient, your assessment starts. So name of the patient, age, gender, room number, admission, diagnosis, and code status. Super easy kind of stuff, okay? All that stuff will come right out of their chart. Background. So this can be interview and chart review for your patients. I have the luxury of working at the VA, and we have outpatient and inpatient care together at the facility. So I have a lot of information on my patient of their background. And sometimes at other hospitals, this is a little trickier to get a background on a patient because it may have been the first time that they've been seen. And so this is going to come from either an interview process or a chart review, or even an admission note from a provider. So you want to know the patient's history, chronic medical conditions, and any previous hospital admissions. And that'll all make sense to us here in a short amount of time. So we want to know the situation, which is essentially where they are, why they're here, what brought them into the hospital, and their code status, because you want to know that on every single patient before you even walk in their room. Background, we want to know what their background is, because we kind of know what we might see. We're already doing some critical thinking stuff here when we see the background before we get to assessment. So situation, background, assessment. The assessment part of it is what we're going to primarily focus on in this class. So this is going to be your assessment of the patient. So here's stuff that we've determined before we walk in the room, and here's stuff that either the therapist prior to us on shift gathered if they're giving us a report on this patient, or if we're giving report on this patient, or we're writing down information on this patient. These are things that are super important, because this is what we found on our pulmonary assessment using the tools that we're going to learn in this class, okay? So we do a pre-assessment, a one-time assessment that includes, it's a little more in-depth. We do our therapy and education, so why we went in there to see the patient, and we're going to tell them why. And then we want to do our post-assessment. So we do a pre-assessment, a one-time assessment at some point in this, and we'll talk about this in depth later. We want to do our therapy, why we were ordered to see the patient, and education. This is why we're doing this with the patient. And then the post-assessment is very important because we want to know if whatever we're doing is making this better. So is our therapy working? Is it effective? That kind of stuff. Recommendations, changes or additions in therapy. Whoops, got crazy there. And so changes in acuity. So if we're giving report and we're making recommendations, we think the patient needs a different medication. We think the patient needs a different frequency with this therapy, or this patient wasn't doing well when we took over today, but they're doing better now. We feel like their acuity is better. Or if your patient's changing for the worse, like I think we need to step it up a notch, or maybe get the physician involved because we need to make some changes in their therapy. So changes in acuity are really important. So this slide will come up through the entire class. As far as the format you will use when discussing your patient with other providers, nurses, physician's assistant, nurse practitioners, MDs, and yes, you will be talking to doctors. So it's nice to have this organizational format when you're discussing with your provider. You may not need to tell them the patient's history or their room number. Well, you will have to tell them their name and room number so they know who you're talking about, but you won't have to probably repeat the history. They need to know why you're talking with them and what you need from them regarding their patient. So it's nice to have yourself organized so that when you're talking to a provider, you feel like your whatever recommendation part, so the R part of this that you're making, is based off your assessment skills or based off, that kind of stuff. So super important. The situation, again, name, age, gender, room number, admission, diagnosis, and code status. So Mr. Smith is a 67-year-old male in room 312. He was admitted for a COPD exacerbation. He's a full code. So that's how you kind of would start your your report, or you would get report. That's kind of how that would work. Okay, history. Obtained from patient's chart or interview process, any chronic medical conditions he has, previous hospitalizations, surgical history, if it pertains to the cardiovascular assessment. Like, we don't need to. If your patient's had a lobectomy or has had some sort of a lung surgery where you're going to see something funny in your assessment, it's nice to mention it in the background part of your Sbar, so that you're not panicking all of a sudden if you don't hear any breath sounds in a certain area. And if you already know that the patient's had a lobectomy or had some sort of a lung reduction surgery, you may not be quite as alarmed if your auscultation doesn't go according to plan. So it gives us a good idea of what we're already going to see, or we can use our critical thinking skills to think what this patient may need from us before we even see him, if we have a good background on this patient. So again, it can be obtained from their chart or the interview process. The assessment part, findings from your most recent assessment, to include breath sounds before and after, and that's what we're going to learn about in a little bit later today. Heart rate, respiratory rate, SpO2 and FiO2. We are going to learn about all of these. So any abnormalities found with our assessment tools. So that's what this class is going to teach you, is how to, what these mean, how to, how to get them, what they mean, and how to report those. And we'll make it make sense when you're in the clinical setting. So our assessment part is our findings from our most recent assessment, typically, to include these things, and we can talk about that later. Recommendations, like we talked about, treatment plan changes. Do we need to change something? Do we need to change their treatment or therapy frequency or times? Do we need to change their pharmacology a little bit? Do we need to add something, take something away? Those are the kind of things we're going to see in the recommendation part of our Sbar. Okay, I think we'll pause there, and I will put this one to YouTube for that amount of time, and we'll pick up on the next one here after. That'll be on the next YouTube video. So I'm going to pause here, and hopefully we can learn this all together over Zoom tomorrow, but if not, we've got it on here today.